So, my guest today, I'm very, very honored to have Dr. Chris Palmer. And Dr. Chris Palmer is really leading the kind of revolution that I always dreamed of in psychiatry. He's assistant professor at Harvard, where he runs education programs. But as you will discover, this goes much, much deeper. And we're talking about a new expression, which I guess we could say is metabolic psychiatry. And I hope it is going to cause the kind of paradigm shift that we've been dreaming of in relation to mental health. And it's sort of a little bit of a sort of history here, Chris, because back in the 70s and 80s, when we started the Institute for Optimum Nutrition, you may recall Dr. Abram Hoffer and Dr. Carl Pfeiffer. And I, as a psychologist, sort of becoming nutritionist because the brain invited them over to the UK, took out advertisements in the British Journal of Psychiatry, invited all psychiatrists, and virtually none came. So then you wind the wheels forward a bit to, let's say, 2015. Very nice article in The Lancet by many people that you and I will know saying nutritional medicine should be mainstream in psychiatry. But what's interesting here, and I'd like to start by kind of defining a little bit the territory, is metabolic psychiatry is an evolution of a systems-based approach as I see it. And it's not just nutritional medicine, it's not just nutritional psychiatry. So what are you getting at when we talk about metabolic psychiatry and the fundamental premise in your book, which is brilliant, called Brain Energy?
Well, thank you for having me on and for this opportunity to have this conversation with you, and for your flattering words of introduction. Ultimately, as an academic psychiatrist, I, along with countless other psychiatrists, psychologists, mental health professionals, neuroscientists, patients, and families have been desperately seeking answers to the question, what exactly causes mental illness? And the reason that question is so important is because our treatments fall short in so many ways. There are millions and millions of people who are doing everything that they are asked to do by their mental health professionals, and they end up suffering in profound ways. They live second-class lives. Some of them end their lives prematurely. And even if they do everything right, some of their lives end prematurely through no fault or no control. And ultimately, what I have proposed in my book is that the science, once and for all, has finally come together, is beginning to come together in a coherent way. And that way is that mental disorders, the disorders of the brain that we call mental illness, and I distinguish that from normal human suffering, and we can get into a more nuanced discussion of that distinction. But the brain disorders that we call mental illness, largely across the board, are in fact metabolic disorders impacting the brain. And that as we begin to understand that science and what it means, it opens up entirely new ways to think about treating mental illness. And foundationally, so much of the work that you referred to in introduction, it builds on that. It suggests that there are, in fact, root causes of mental disorders or metabolic dysfunction, and that we can systematically assess these root causes, we can identify them, and we can treat them. And this holds tremendous hope for really countless people.
And when you say metabolic, I mean, there's two expressions I really like in your book. One is, rather than talking about risk factors, contributing causes. And when we talk about metabolism, which is a sort of general word, you really focus in on these contributing causes, which could be nutritional, they could be stress, they could be exercise, they could be environmental in many different aspects. You really focus in on the magnificent mitochondria, which again have been quite limited in their concept as the energy factory in cells. But your book, Brain Energy, makes it very, very clear. I mean, you know how people say the gut is the second brain? Well, after reading your book, I kind of think the mitochondria, is really, those mitochondria are functioning in a very central and all-pervasive way. So you lead, so many paths lead to those mitochondria and dysfunction in those mitochondria caused by many things. Is that?
It is correct. So to add a little more to what you said, that most people, if they've even heard of mitochondria, they think powerhouse of the cell. And by that phrase means that mitochondria are taking the food that we eat and converting it into ATP, or energy. And in fact, mitochondria do that. There is no question about that. They provide at least probably 90% of the ATP in the human body. And without them, we would die pretty quickly, within minutes, because we need energy in order to stay alive. I think that the thing that has really transformed the field, or at least holds the potential to transform our field, is all of the research that has occurred on mitochondrial functions over the past 25 years in particular. That most researchers up until 25 years ago really thought of mitochondria simply as powerhouses. That some described them as little batteries. Mm-hmm. They were just these tiny little granules in cells, and they would just take in food and churn out ATP and use oxygen in the process of that. But that's what they did, is they just little power factories churning out ATP. And so, of course, batteries are important, but they're nothing more than that. And the research over the past 25 years has completely shattered that simplistic notion that mitochondria, in fact, are playing key and critical roles in numerous cellular functions, such as the production of steroid hormones, which include cortisol, estrogen, testosterone, the production, regulation, and release of key neurotransmitters like serotonin, dopamine, GABA, glutamate, the turning inflammation both on and off, epigenetic regulation. They are one of the primary regulators of gene expression from the cell nucleus, and yet they have their own little set of genes as well. And I could go on, but the reality is that these additional functions of mitochondria allow us to once and for all tie together the biological, psychological, and social factors that we know play a role in mental illness. But of course, it's not just limited to mental illness, it's also many physical illnesses. And it's a way to put it all together.
And that is a phenomenally systems-based approach. And our whole culture, and we're not just talking here about medicine, but we're also talking about people and patients. They want a quick fix. What do I do for my depression? What do I do to prevent, dementia, memory loss, and so on? And I've read your book twice, and in some ways, it started off being a little bit frustrating, because there's so much to learn and understand. It makes the whole story so much bigger. Then I would say it moves to complex, but then I would say it moves to connected. You start, as you move through the book, and especially, I felt it was worthy of 2 reads. You start to realize how all these factors, from stress to exercise, our state of mind, our nutrition, there's so much that all feeds together, that is all connected. It felt to me like a tipping point. What is it that supports that central metabolic function focused in the mitochondria, and how do we create those circumstances? And it took me right back to Darwin, because Darwin said there are 2 driving forces of evolution. One is conditions of existence, and the second is natural selection. But he said in everything he wrote that conditions of existence was the more important, because it's only when conditions of existence change that natural selection, e.g. which species or subspecies do better, kicks in. So here we have this approach of it's the conditions that we have and sometimes create in our life that then has this escalating knock-on effect that now goes straight into our biology. And what you've done is to map out so beautifully how that occurs in the mitochondria. So for anyone who takes this approach on board, and my dream and hope, is that psychiatry will start to take this approach on board, it changes the game, because it's no longer about one thing. And I know in my work in Alzheimer's, everyone right now has a theory in Alzheimer's. It's type 3 diabetes, it's aluminium, it's omega-3, it's how much you use it. And I think that was the fundamental point that you really get across. We are all different. There are a number of factors, but now you've actually mapped out how those factors actually contribute to the processes that lead to the mental illness that we see, bipolar, schizophrenia, depression, and so on. I have a few specific ways. Is that a fair appraisal of the situation?
It is. I think that, and I'll add just a little bit to it. So the reality is that if you want to understand, so what are the conditions that account for all causes of all of the different mental disorders, it's overwhelmingly complicated. There are so many factors. And we can't throw away what we already know to be true. So of course genetics play a role. Of course infections and inflammatory cytokines can play a role. Of course toxins can play a role. Of course trauma and stress and adverse childhood experiences play a role. All of those things come together. What this changes, at least for me as a psychiatrist, and I hope for others, is that it offers a framework to finally once and for all make sense of it, to put it together so that it becomes a solvable puzzle, as opposed to just it's overwhelmingly complex and no one understands it. Because right now, that is where 99% of our field is. They say it's overwhelmingly complex and nobody can figure it out. It's just too complicated. And we're doing our best for the patients that we serve. We're trying pill after pill. We're doing different types of talk therapy. Sometimes we're applying electricity to the brain. We're doing all of these things in the desperate hope that something will work. But we have no idea or understanding of why these things work, really, because we have no idea what really causes mental illness. And what I believe is that the science has now come together, that we have enough science to say, no, we do have a map. We have an outline. We have a structure. that helps us understand what causes this metabolic dysfunction, what causes this mitochondrial dysfunction, and we can put it together and help people heal and recover. Now, the great news is that for probably 60 to 80% of people with mental illness, it's not that complicated at all. It comes down to basic lifestyle medicine principles. So we're going to look at diet, we're going to look at exercise and movement, sleep, harmful substances, connections, relationships, purpose in life, and stress reduction. Those are kind of the 6 pillars of lifestyle medicine. And we're going to do all of those. And I believe if we do them in the right way, so there's not a one-size-fits-all diet for everyone. Which diet is going to serve which patient can get a little complicated, but it's not rocket science. Dietitians know how to do this. Clinicians should be able to do this. It's not that complex. But not everybody gets the same diet. And why do I say that? Because some people might benefit from gaining weight. They might be malnourished or starving to death. While others might benefit from losing weight. They might be obese. So those are 2 different dietary strategies. But again, your listeners already knew that.
Okay,
so
let's dive into a few little detail areas,
Yes, because
I very much want to look at the sort of politics of how we actually make this happen. But when you talk about, mitochondria, producing energy, but actually having so many functions, and they can function on glucose. There's a lot in your book about problems with glucose and too much glucose and so on, and they can also function on ketones.
Yes.
And one of the members of our group, Professor Stephen Kinane, has shown how it's the C8, particularly that 8 carbon long medium chain fat that generates ketones. So going into a little bit more detail, where are you on this spectrum of what we could call a low glycemic load diet that a lot of people, myself included, have been advocating? Less carbs, complex carbs, always having fiber, eating fruit, not drinking it, and so on. Over to the area of a ketogenic diet that is actually generating ketones measurably, the extreme of which might be a sort of autophagy type fasting mimicking diet. But in your experience, where do you fit? You may say, it depends on the person very much.
It very much does depend on the person. And I think the one thing that I would love to say just to start this conversation on diet is I think people think about diet oftentimes in too simplistic of a way. They think that if you're eating the right diet, whatever that right diet is, if you're eating the right diet, everything will be fine. And in fact, dietary patterns and what you do with eating or timing of eating or not eating or mimicking fasting, what you do with those things can represent very different strategies for prevention and for treatment. So it is true that humans need a foundational healthy diet. And if an infant is born and otherwise healthy, feeding that infant on through childhood and on into adulthood a quote-unquote healthy diet, lots of controversy about what that looks like, but if you feed that growing human, a healthy diet, it likely will play a profound role in preventing illnesses, preventing chronic diseases, including brain conditions that we might call mental illness. But there are dietary patterns, such as fasting in the ketogenic diet, which mimics the fasting state, that I actually think of more as interventions, that they are actually treatments. They are treatment strategies that may or may not have anything to do with what your diet was like prior to starting the strategy. So fasting is the absence of food. It doesn't matter what you were eating beforehand. You could have been on a whole food plant-based diet. You could have been on a Western diet of highly ultra-processed foods, or an all meat diet. You could be on anything you want. And if you fast, all of those people, if they fast, will get similar biological metabolic effects from the process of not eating.
Mm-hmm.
And fasting mimicking diets mimic much of that, and that's the ketogenic diet. And so the reason I point this out is because I'll give one extreme example that is relevant to brain function: epilepsy.
Mm-hmm.
So there are humans that are born who have genetic differences that predispose them to have seizures that are sometimes uncontrollable. So the root cause of that person's seizures is a genetic allele, a genetic difference from others. That is the root cause. That root cause leads to metabolic dysfunction in the brain that can be treated with a ketogenic diet in some cases. And for some of these, glucose 1 transporter deficiency syndrome, for example, the primary treatment for this genetic disorder is the ketogenic diet, the first line treatment, and it's a treatment for life. Now, that doesn't mean that the diet caused their problem. Mm-hmm. A bad diet didn't cause their problem. A genetic defect caused their problem. And yet, a diet can be a very powerful, life-saving treatment. So that's the way I think about it. And so, back to your question, where do I lie on the spectrum? I'm all over the place on the spectrum. Because some people are otherwise quite healthy on the diets they are consuming, and I will wholeheartedly encourage them to continue consuming the diet they are consuming because they are so healthy. And I don't care if it includes a lot of plants or animal-sourced foods or whatever. If all of their biomarkers are good, I'm going to say probably keep doing what you're doing. It suits you well.
Do you think that ketogenic diet, I mean, epilepsy is an example of it, do you think, we know it promotes GABA, so is it, is it something that has the potential to calm down over-excitatory states? And I'm talking here about, mania, delirium, maybe labeled schizophrenia and so on, epilepsy, as an example of a kind of neurological storm in a sense. So do you think that that's a major part of a ketogenic approach?
There would be one exception. So my work for many years now has actually been using the ketogenic diet for severe mental illnesses: bipolar disorder, schizophrenia, schizoaffective disorder, chronic depression, OCD. And in fact, I have seen now hundreds of patients, or heard from hundreds of patients, really heard from thousands of patients from around the world, who are putting their chronic mental illnesses into remission using the ketogenic diet. And I think that the ketogenic diet is doing more than simply calming hyperexcitability, although that is one of the things it does. We actually know numerous mechanisms of action of the ketogenic diet because researchers have been trying to figure out for decades, how does this diet stop seizures? Mm-hmm. And so we know that it changes neurotransmitter systems. GABA, glutamate in particular have been a focus, but it changes adenosine signaling, it changes calcium signaling, it changes epigenetics and gene expression, it changes inflammation, it reduces brain inflammation, changes the gut microbiome, and some researchers are really hot on that trail and thinking that those microbiome changes are resulting in the brain changes that we see. Specific to my work, it changes mitochondrial biology. It improves mitochondrial function through two processes. One is called mitophagy, which is kind of the replacement of old or defective mitochondria with new ones, and then mitochondrial biogenesis, in which the cells actually get more mitochondria. But the bottom line is that the ketogenic diet can be a powerful treatment for mental illness. The one exception that you mentioned that I'm going to put out there, just word of warning, you mentioned mania. And I think that it can be a very powerful treatment for bipolar disorder itself. But as people transition onto a ketogenic diet, I have seen numerous times people can actually get hypomanic or even manic during that keto adaptation phase. So there is some risk with a ketogenic diet when using it in patients with severe mental illness. And that's one of the primary reasons that I usually recommend it. If you have a severe mental illness, like bipolar disorder or schizophrenia, please get help. It's not get help because the ketogenic diet is so dangerous. It's because your illness is so dangerous and you need help to get you through that illness and treat that illness effectively.
And can some of that be a rebound, blood sugar thing, when you're transitioning into ketogenesis?
It can be. So one of the first things that many people notice in the first few weeks of the ketogenic diet, they will go through several days where they actually feel awful. They feel drained, weak, kind of lack of energy. They will be ravenous. They really want carbohydrates. They really want something with carbohydrates in it. And they will get irritable, everything else. That is normal for most people to go through. Once they get through that phase, which usually lasts maybe up to a week, a few days to a week for most people will get energized from the diet. They will notice that something switched. It was like it really feels like a switch that just got flipped, and all of a sudden they have energy and they're losing their cravings for carbohydrates. They're sleeping a little bit less. They've got more motivation and energy. For most people, this is wonderful. It feels great. They love it. But for patients with severe mental illness, I just have to caution. It can be a dangerous transition period because the patients that I treat with bipolar disorder and schizophrenia, if they go for 2 or 3 days without much sleep, that can trigger a whole cascade of symptoms and episodes that can become quite dangerous. And somebody needs to be supervising this and be prepared to manage it. And I do manage it. I don't stop the diet. I make sure they get sleep. We make sure everything's safe, but we get them through that period.
Do you ever use C8 oil to accelerate that process? And do you measure the ketone level? I was talking to Tom Seafried, and the GKI, the glucose ketone index. Is there a kind of zone that you want to get people into?
There is. So I typically just use MCT oil, which has C8 in it. And that actually enhances the effectiveness and makes the ketogenic diet easier to do for most people because they will get higher levels of ketones. When treating severe mental illness, I do look for higher levels of ketones, usually greater than 1.5 millimole. Blood ketones if possible, somewhere between 1.5 and 3. Because if they go too high, that can become a problem. So you really don't want them as high as possible. Somewhere between 1.5 and 3 seems to be an ideal range. I've had some patients who've done well, slightly higher than that. I've had patients who've done well, slightly lower than that. But that seems to be the sweet spot for a lot of people. Their glucose levels will change depending on where they start. And those will change rapidly over the first few months. But so if they come to me with type 2 diabetes, their glucose levels are going to gradually decline. They're not going to be 70 overnight. If they're averaging 200, they're going to slowly but surely gradually decline over weeks or months. They're not going to be completely normal right away.
One of the things that kind of shocked me in a very positive way with Stephen Kinane's work is my assumption always was to get the benefits of ketones, I've got to really go on a very low carb diet. And then what Professor Stephen Cunnane did with people with mild cognitive impairment or pre-dementia, and he excluded diabetics, was to give them MCT oil and or placebo, and measure the amount of energy produced in the brain from glucose and ketones. The glucose energy production, which we assume was low, didn't change, but he got a 230% increase energy from ketones, not by changing their diet, but by adding in these MCT oils. And I thought that was really, really fascinating. In other words, can I, maybe I don't have to drive those carbs, completely down in order to get the benefit from ketones and C8.
There's no doubt that I would love for there to be a ketone supplement that all of my patients could take and get the exact same benefits of the ketogenic diet. That would make everyone's lives easier, including mine. I welcome that. I will say for the record, I have tried with many of my patients to have them take ketone supplements, whether they're the ketone salts or esters or all sorts of preparations. And for the most part, I don't see the same benefits with ketones. And the way that I understand that is that I think ketones are simply a biomarker. So yes, ketones are a fuel source. Ketones are also a signaling molecule that have profound effects on cell function, genetic expression, neurotransmitter function, all sorts of things, inflammatory biomarkers. So ketones are a fuel source, which Dr. Cunnane was measuring, the fuel and the production of ATP, but they are a signaling molecule. Ketones, ironically or interestingly, are produced by mitochondria, primarily in the liver. So liver mitochondria are producing the ketones that get sent up primarily to the brain for their function. I actually think the benefits of the ketogenic diet may be more about the changes in mitochondrial function and biology than in the ATP production itself.
So we're talking here about the autophagy or mitophagy, as we call it, that the change in that energy supply to the mitochondria creates new mitochondria, cleans out damages. Is that what you're talking about?
Cleans out, yes. So I think cleaning out damaged mitochondria can reduce something called oxidative stress, but can also, and then producing more mitochondria in the cell makes that cell more resilient. And we see that across numerous species. The more mitochondria, the more healthy mitochondria, I should qualify it with healthy mitochondria. Yeah. The more healthy mitochondria a cell has, the more resilient and robust that cell will be. That cell will be capable of performing better. So if it's a muscle cell in a marathon runner, the more mitochondria in that marathon runner's muscle cells, the longer that runner can run, and the more endurance that runner will have. That runner's muscles will be less likely to become fatigued or start spasming or anything else, and they will just power on and carry that runner to the finish line.
Let me switch the conversation and ask you, it's kind of about supplements, but it isn't really just about supplements. You mentioned the tremendous importance of thiamine B1, folate, B12, methylation we know is so important. There's a lot in the book, mentions of GABA. GABA is an amino acid, but it's also a neurotransmitter. In America, you can buy it over the counter. In the UK, you can't. I was also studying a lot of the effects of antidepressants. And let's face it, if we're treating people with depression, the chances are they're on antidepressants. And whether or not the linear notion, which I don't exactly buy into, which is, if you're lacking serotonin, it's the mood thing and the antidepressant will boost your serotonin and so on. What seems to be a lot more consistent is if you've been on SSRIs or SNRIs for a couple of years, it is very likely that you are serotonin depleted. So the context of this is my thinking has been, and I have treated people sometimes with GABA to accelerate a kind of calming effect, sometimes with 5-HTP tryptophan or 5-hydroxytryptophan to correct some underlying deficiency possibly created by medication. I very often am using methylation support nutrients, that is B vitamins, always looking towards the essential fats, the brain fats, the omega-3, particularly vitamin D and so on. But here in the UK, there is a medical blind spot verging on paranoia regarding the use of nutritional supplements. So where do you stand in that whole field?
It's a great question. So I've spent most of my career being a very traditional Harvard psychiatrist. And so for the most part, I was open to a handful of supplements, but not many. At this point, especially since my book came out and my work is getting more attention, I've actually been approached by numerous supplement manufacturers, biotech companies, and others that are all working on products that in one way or another are purported to support mitochondrial function. And some of them have amazing, robust, replicated data, and others are not quite far as along, I'll say. And some of them are in their infancy. And just because something's in its infancy and they don't have the robust data yet doesn't mean it's not going to be a blockbuster supplement in the future. It just means we don't yet have the data for it. So, but the reality is it's an overwhelming field. It's overwhelming to think about which supplements, at what doses, for how long, for which patients. And how do we figure all of that out? And we can figure some of it out. But so in many ways, I'm actually quite excited about the field of vitamins and supplements and other supports that we can offer patients. At the same time, I'm a bit overwhelmed by how many there are, the quality control of the different ones, whether some are methylated or not methylated. Does it matter for everyone? Mm-hmm. Which supplements, which vitamins, how do I go about determining that? But I will tell you my bias. I do have a bias. And one bias is that I do think there is such a thing as over-supplementation. Just like I think people can be over-medicated with prescription medicines, and being on 12 prescription strength medications can actually be harmful in some cases. I believe the same is probably true with supplementation.
Have you seen that?
I was personally first exposed to that over 25 years ago with vitamin E. Mm-hmm. So vitamin E at one point in time was the vitamin. Everybody was talking about it. It was going to save all of us from heart attacks to Alzheimer's disease to schizophrenia. We were putting all of our patients with schizophrenia and bipolar disorder on vitamin E. High doses, the higher the dose, the better. Why not? How you can never have too much antioxidation. Like the more, the better. And then a rigorous controlled trial was conducted, and I believe thousands of people. We had numerous trials for heart disease. They were negative. Alzheimer's disease prevention, negative.
But harmful?
But high doses, 2 vitamin E pills a day, 400 international units a day, higher mortality than the people who got 1 vitamin E pill or the people who got placebo. 2 vitamin E pills a day. And that study actually changed the field. I noticed people aren't talking about vitamin E as much anymore. Nobody's talking about vitamin E.
Well, no, you're right. And the dose, came down to sort of like 100 IUs being a good place to be rather than, 1,000 back in those days. We have a very simplistic approach at Food for the Brain where we are reaching literally hundreds of thousands of people, which is. And by the way, I'd ask you a little bit about this because there seems to be a across the pond US, UK, Scandinavia bias in relation to homocysteine. Homocysteine is the marker, for methylation issues. And our view is very simple. And that is, in effect, if your level is above 10 or 11, we want to bring it down. And, the evidence is, beyond established that, vitamin B6, folate, some argument about folic acid versus methylfolate, but even with folic acid and B12, it brings it down. So our view, measure homocysteine. If it's raised, bring it down with supplementation. Also with the omega-3 index, which is the percentage of EPA and DHA membranes. We want it at 8%. Interesting, I was looking at a study where criminals have 2%, the average American and British person has 4%. So we measure it, and if it's raised, so in a sense, the question there would be how much omega-3 is good for you, and the answer is, and also fish, because it's not just about supplements. And the answer is whatever gets you, to the 8%. And similarly with vitamin D, we always measure vitamin D. And if it's below 75 nanomoles per liter, which is the UK measure, or 25, nanograms per liter in America, then we want to give you more. So what is the optimum intake of vitamin D? It's whatever gets your blood level above X, Y, Z. So, so that's kind of like, basic supplement type strategy, also for mental health. Is that?
I think that's right.
Yeah.
I think that's right. And so I love using some type of biomarker or some objective measure instead of just putting people on supplements and not really knowing what our target is. I'm in my practice of medicine all along. I have always been a big fan of don't start something unless you know how you're going to determine whether it's useful or not, and make sure that whatever method you're using will encourage you to continue it if it's useful, but will also encourage you to stop it if it's not. Because if you don't have a process that's going to tell you to stop this medication or this supplement or whatever, then you don't have a good valid process yet. Yeah. And you better figure one out before you go starting, because otherwise that's how people end up on so many pills. And I see them come into my practice, and sometimes I can get them better by just simply removing all of these pills that they've been given.
Well, my wife and I pretty much the same diet, and when we had our homocysteine measured, because we finally developed a home test kit that does it accurately to serum, my level was 7, hers was 15. Wow. I need 10 micrograms of B12 a day to stay at 7. She needs 500 micrograms a day and brought it rapidly, down to 8. So we are so different. So just a slight question there, because I read Dr. Casey Means' excellent book, really a Bad Energy, great book. Not a single mention of homocysteine and methylation. I've interviewed some of your, luckily in America, there's like an army of people now kind of within the metabolic psychiatry zone. I interviewed Dr. Georgia Eid, Umanedu, David Perlmutter, many such people. And more in the US in the field of psychiatry. And James Greenblatt, fantastic fellow. He's really, held the banner for a long time. Some absolutely no mention of methylation and homocysteine, which seems to me, I remember even having this whole approach with Rob Lustig, who's our sugar daddy, fantastic man. And he kind of didn't have methylation in there in there either. And it's so strange. Now, at the moment, I'm working in China. We're actually off next month to launch the cognitive function test there. And they're kind of leading on homocysteine. It's in all of their research. So why is that particular nugget sometimes just overlooked, even in this world of advancing functional medicine, systems-based metabolic psychiatry? What's going on there? Is it just an oversight?
I think.
And do you agree, actually? Do you think it's a fundamental part of the process?
So I think it is a fundamental part of the process, and at least consistent with what I've proposed in brain energy, metabolism, mitochondria. One carbon metabolism, which relates to vitamin B12, folate, and homocysteine, is taking place within an organelle called mitochondria. So homocysteine, in fact, is a sign. High levels of homocysteine, one could easily argue, is an actual biomarker of mitochondrial dysfunction because one carbon metabolism is taking place within mitochondria. And so I don't veer off. So I actually very passionately believe, yes, of course, homocysteine is one of numerous biomarkers that we should be considering. I think the reason so many people are led astray is because we don't have clear protocols and algorithms for the workup of common people with mental illness. And I am really hopeful that we can work on those. They are nothing more than an engineering process. And we need to balance the costs because it will bankrupt society if everybody gets a $1 million workup with every biomarker measured possible and whole body scans and everything else. We don't have the resources to do that. And so we need to be more judicious in our use. But I'm really hopeful that we can come up with protocols in which if somebody comes in with depression or anxiety or ADHD or their first manic and psychotic episode, that they will get a standard assessment protocol. They will be given some basic treatments, maybe step 1, 2, and 3 for treatments. And if those don't work, right now, the system is just keep trying more treatments. You're done with the assessment. You have a diagnostic label. It's called bipolar disorder, and just keep throwing treatments at them until they're dead. And what I say is no. They have metabolic brain dysfunction. They have a metabolic problem impacting their brain. And this, in fact, is understandable. So maybe step 2, step 3, step 4 is going to include different biomarkers for different patients at different levels. Now, I know you are quite passionate about homocysteine and would passionately argue step 1, everybody gets homocysteine. And I don't know that I disagree with that.
Yes.
I would just want to, again, be thoughtful at a population level. Is that practical and is that cost effective?
I think in America, it used to be in those, first level tests that could be done in hospitals and so on, and then it dropped out. I think because it maybe got a bit downgraded in relation to cardiovascular disease. Part of my reason for being an advocate for homocysteine is because I see it as one of the most ignored evidence-based factors. So like vitamin D, I'm passionate about vitamin D, but I don't have to wave the flag on it because everyone's talking about vitamin D. And I loved Professor David Smith's recent paper with Professor Helga Refson, where it is a biomarker for 100 diseases. Biomarker for 100 diseases, including almost, not all, but almost all, mental health diseases. And then I think that the Lancet Dementia Commission, the Lancet Commission on Dementia Prevention, which was a major group of scientists, published first in 2017, ignored homocysteine. We sent them all the papers. Published in 2020, we sent them all the papers, ignored homocysteine. Published in 2024, once more, ignored all the evidence. And I'll just bounce a little bit off that, because omega-3 was also essentially ignored, but in a very strange way, because there was a section in this paper, which is, by the way, a paper designed to tell clinicians what a patient can do to help prevent dementia. And it really focuses on things like air pollution, which is really, really hard to change. Things like homocysteine and omega-3 is so easy to change. And in this case, in the section called insufficient evidence, they cited only one study on omega-3, which was highly effective. I mean, they said, reduced the rate of brain shrinkage, reduced, dementia incidence and so on. And you and I know that any PubMed search, you just click on it, and there are many, many studies. We're not just talking observational, because observational studies on air pollution or smoking, we're talking randomized clinical trials, supposedly the gold standard, in that context. And so it would have been so easy just to look at the 12 really robust omega-3 studies in relation to dementia. So yeah, my focus there was really on this sort of double standards, in terms of science. And one point that I would make, and I hope you would agree, is that when these randomized placebo-controlled trials are done, which can't be done on diets, you can't do a randomized placebo-controlled trial on ketogenic diets, but you can actually on omega-3 or B vitamins. There are two sort of blind spots. One is when you do a trial on a drug, you're either 100% on the drug or you're 100, you're 0%. It's just the way it is. But when you do a randomized controlled trial on omega-3, no one is on 0% omega-3.
Yeah.
So there's the whole background. So if you don't actually assess a person's status, you may get a null effect because they actually, a number of them already had omega-3. And the other thing I find so kind of obvious and yet so ignored in so many studies is you do a study where the effect may be present or small or close, but not quite, statistically significant. And I always want to know who got an effect and who didn't. We're talking about subsets.
Yes.
So we don't expect that everybody will respond to a ketogenic diet, with bipolar. Some will and some won't. And one of the critical questions is, what's the difference between those who do respond and those who don't? So my emphasis on homocysteine has purely been, with 30,000 studies published, really good randomized controlled trials. And I think you're aware of the astonishingly important discovery, that's really been solidified the last few years, that the homocysteine lowering B vitamins do not work without sufficient omega-3. And omega-3 does not work without sufficient methylation. And that's for the very simple reason that neuronal membrane. And perhaps that's another piece, there we've got the mitochondria, which I would say, if we say the gut is the second brain, we could say the mitochondria is at least the second brain, maybe even the first brain. But then there's that membrane, that very, very important, pathway that brings everything in and out.
Yes.
And that membrane is phospholipids attached to essential fats.
Yes.
Done by methylation. So if you lack the essential fats or you lack the methylation, it ain't going to work. And then you don't have the right talking going to your magnificent mitochondria.
Well, exactly. And mitochondrial membranes themselves include omega-3 fatty acids.
Yeah.
And when they don't, that impairs their function. So mitochondrial membranes are actually extraordinarily important because the mitochondria are actually fusing with each other and budding off from each other and actually engaged in all sorts of morphological dynamics, what they're called. But when mitochondria take different shapes and conformations, it changes the function of not just the mitochondria, but it changes the function of the cell. They're different shapes and conformations. And omega-3 fatty acids and omega-6 fatty acids play a large role in mitochondrial membrane function. And so it's not just the cell membrane, which of course is important. I'm not here to say it's not important at all. Of course it's important. But I want to throw yet another wrench in the works that, what about the mitochondrial membranes? And then what does that do? What does the lack of omega-3 fatty acids, or at least a paucity of omega-3 fatty acids, do to the function of mitochondria? And does that impact the function of the cell? And based on the evidence that we have right now, there's every reason to believe that, yes, it would play a role in mitochondrial function and the function of the cell. So I agree with you. And I liked what you said about not everybody responds to a treatment. And we know that with even all the traditional treatments, psychotherapies, or antidepressants or antipsychotics or mood stabilizers. Some people respond beautifully, absolutely magnificently, and they are seemingly cured or mood stabilized with a treatment, and others can try treatment after treatment and they're not getting better. So I agree with you that when we're doing omega-3 fatty acid studies, for example, why not measure everybody's omega-3 fatty acid status prior to starting the double-blind, randomized, placebo-controlled trial, and then also measure their levels during the trial, and then most importantly, see does an increase in omega-3 fatty acids correlate with improvement in the outcomes that we're looking at,
and also measure methylation.
Because
I said that to Bill Harris, wonderful Professor Bill Harris. Do you find people with the same intake of omega-3 have different omega-3 index levels? And I said, have you thought that it could be to do with homocysteine? If you don't have that methylation, you can't incorporate the omega-3s, and you won't find them in the membrane.
So, I like it.
I'd like to switch the conversation into another area. One of the things I loved, I think you and I might share quite a lot in common. I had a chronically depressed mother. And I kind of went into psychology, thinking I would go into psychotherapy, and I studied with all sorts of people. Roberto Assagioli, psychosynthesis, some of the early, really, really interesting approaches. And, so that was, very much my orientation. So when I got to study experimental psychology at university, one of the first questions I asked is, are we going to do anything on love? Now, I saw that 4-letter word in your book, and it made me smile. And they said, good heavens, no, we don't do love. And I said, but I thought, love makes the world go round. It's a very important construct, if nothing else, for us. We all know kind of what we mean, by love. So I thought that was very, very interesting, and very pleased to see that in your book. And I also liked the research you quoted about social isolation, leading to overeating, and overeating depleting energy. I thought that was a very sort of interesting topic, and it got me thinking about those visceral feelings. Sometimes you feel something, and we're talking about the axis, from sort of the chest, down to the belly. And we all know there are feelings, and sometimes you feel this ache in the heart, or this emptiness, or something in the solar plexus, or, a gut-wrenching, type feeling. I'm very interested in those kind of visceral sensation feelings, because they also sometimes are not so different to hunger. That hunger is like that visceral, drive. So this interesting connection. I'm very interested in how those, psychological experiences link into our biology. And here they may even do so, across some similar sensations. So I loved that section in your book and how those things connect. Anything you'd like to say about that?
Yeah, I'll speak just even more broadly that, a lot of people hear me talk about metabolism and mitochondria, and they think that I'm I'm reductionistic,
Mm-hmm.
that I'm reducing
You're a biologist.
mental illness to biology and nothing more. And so I'm glad you brought this up, because I want to be very clear. I'm a clinician. I've been a clinician for almost 30 years. You cannot be a good mental health clinician if you're unwilling to consider or talk to people about love, or about purpose in their life, or stress, or trauma. Any decent clinician knows that those play a profound role in mental health. We also know from large studies that they play a profound role in physical health as well. And what I'm hoping is that this research that's been done, looking at metabolism, mitochondria, and people like Dr. Martin Picard, who calls himself a psychobiologist, mitopsychobiologist maybe, he's looking at psychological impacts on mitochondrial function that then impact the organism as a whole. And that's really his area of research. I'm hoping that we can connect it all.
Mm-hmm.
There is no doubt that love plays a role in human health. There is no doubt it plays a role in human existence. We, for better or worse, sometimes I kind of wish we had the option of opting out and doing it our own way.
Mm-hmm.
But we don't. We are hardwired to want and need other people, because we as a species are a social species. We do better. We are more likely to survive if we stay in a group. That's why when people are shunned by society, when people are humiliated, they don't go out into the middle of the woods and live independently. It would solve a lot of their problems, but in reality it wouldn't solve their problems, because they would be at great risk for death. And so this concept of love is really about acceptance. It's about safety. It's about being known and being seen, being respected, being cared for, knowing that if life gets really tough, somebody will help you. Somebody will be there for you.
And what I love in your book is, we're starting to sort of move into those territories where psychological, social, environmental, contributing causes, feed into, biology, including the mitochondria. It's just,
Absolutely.
They do. And I really want to share one thing, because one of the most influential psychologists that has really driven so much for me is a Bolivian man called Oscar Chazo, not very well known. And I thought you might like his theory of the doors of compensation. And this related not only to your chapter on drugs and alcohol, but this idea of social isolation leads to overeating and so on. And his concept there is that our psyche is like a container. And when something happens that does not fit our concepts, for example, someone dies, or something tragic occurs, or something extraordinary happens, in that moment it creates so much pressure in our psyche, a bit like too much steam in the container. Now, in an ideal world of enlightenment and Buddhism, one would expand one's consciousness to be able to deal with the realities of life. But in the moment, there's too much pressure. And he says we compensate. and we compensate through certain doors of compensation. And one of them is gluttony. In other words, excess. It's a numbing agent. In the same way, another is toxomania, which could be alcohol, drugs, cigarettes, whatever it is, but it's a numbing thing. We're actually choosing in that moment. Another is cruelty. You become grumpy and irritable and whatever. Another is actually overexertion, workaholism to the point of exhaustion, or exercise, over-exercising. But in other words, the model says that in a time of pressure and stress, we have to let off steam, and we choose to do the very things that ultimately will deplete our energy, numb us out. And in that moment, the doors of compensation. Interesting model. I thought you might like that.
So at the end of the day, the behaviors associated with stress and isolation and other adversity, the behaviors are clear. I tend to take a slightly different lens to it. I am always looking for the evolutionary advantage of that behavior, because those behaviors are seen in every society throughout the world. And so it does seem to be something that's hardwired into humans. And so I don't see it as all bad. I actually see it as potentially adaptive. And the way that I rationalize overeating in the time of stress, for example, is that when a human is being shunned by his tribe, it might mean that he will become an outcast or put in a jail cell or something for a short period of time as punishment. But either one. And in either case, he may have to go without food for a sustained period of time. And I would argue it is quite adaptive for him to overeat, consume as much food as possible in this stressful time, because you never know where your next meal is going to come from.
Yes,
Now, in our society, of course, that's preposterous, and we have access to food 24 hours a day, 7 days a week. But that hasn't always been the case. And so I actually think it might be adaptive, almost like when animals that hibernate sense that winter is coming, they put on profound amounts of weight. They eat ravenously and they store excess fat because that's adaptive. It's going to get them through the long winter. And so I think of it the same way. Now, obviously, if what
about over drinking? Let's say you're grieving, and then you hit the bottle.
Yes.
Which, of course, creates unconsciousness. So the numbing effect of alcohol.
There's zero doubt in my mind about the numbing effect of drugs and alcohol. I 100% aligned with that. That I am in so much pain that I don't want to feel this. And if anything can make me not feel it,
I'm there.
I'm there. I will welcome it.
Now, to end our wonderful conversation, I want to say that everything you're doing is just so wonderful, because this is the psychiatry that I certainly have been dreaming of since I entered this field in the late 70s. And my final question, exploration, is how are we going to make this paradigm happen? It's a whole new approach, we can say, within psychiatry, but I almost like to broaden it, because it's not just that psychiatrists are the only people in charge of our mental health, but how are we going to make this paradigm shift happen? And what are you up to help make that occur?
So I'm actually really excited, because I actually think the paradigm shift is happening. It's starting. In the United States, the American Psychiatric Association, the president chooses a theme for the annual meeting, and the theme this year is lifestyle medicine and its incorporation into the field of psychiatry. I think mental health professionals in particular are desperate for new tools to help their patients. One of the most hopeful things, I believe, about the field of psychiatry, more than almost any other medical discipline, is not the psychiatry itself, but all of the other mental health professionals, the psychologists, the social workers, the therapists, and others. They outnumber the psychiatrists by far. They are the mental health workforce by and large. And the pharmaceutical industry has almost no influence over them because they are not prescribers. They are not interested in prescribing. They chose their fields for a reason. They weren't interested in prescribing pills. They are interested in spending 45 to 50 minutes a week with patients to help them heal and recover. And I believe they may very well be the key ingredient in truly transforming the mental health field, because they are a workforce that sometimes has weekly access to patients, that has no interest in prescribing more pills, that is not going to be dissuaded by the pharmaceutical industry, that they are often already very skilled at behavior change. They help suicidal patients reduce their suicidal behaviors. They help patients who cut and self-injure to change that behavior. They help alcoholics stop drinking alcohol. They help patients change all sorts of behaviors. And this work is perfect for them.
So we need to train them.
We need to educate them, empower them, train them, and let them more effectively help all of their patients.
Now, I know that's one of the plans at the Institute for Optimum Nutrition as part of an MSc on mental health and this whole approach. I get the sense things are happening a bit faster in the US than the UK.
I'm not convinced that's true, but we are getting attention. So, the great news is, the not great news is that we have an election coming up in the United States. And so the country is polarized. It really is a tight election, 50-50, which means whatever side of the political spectrum you happen to reside on, just know that 50% of the country vehemently disagrees with you and has a different opinion.
Yeah. And I was seeing that launch of MAHA, isn't it? Make America Healthy Again.
And that's what I was going to bring up, is regardless of your political affiliation, Robert F. Kennedy Jr. has gotten attention. Mm-hmm. And this Make America Healthy Again, and is really focused on chronic diseases. I think a lot of people, when they think of chronic diseases, they are mostly thinking of obesity and diabetes and metabolic disorders. And I am passionately running after all of them, throwing in mental health. Remember mental health, everybody. Remember mental health. Yeah. Because we have an epidemic of mental disorders as well. Yeah. And they are interconnected in every way imaginable, in terms of the biopsychosocial risk factors, in terms of the cell biology, as we've discussed. And so I think there's tremendous opportunity. I've been meeting with senators, congressmen and women, and others who are actually very passionate about doing something about this once and for all. I am talking with, hundreds of clinicians who are interested in learning more about how they can begin to implement these skills. I really do believe that the time is right. And ultimately, I've been asked this, why now? Why now? Why are you getting so much attention, Chris? Somehow you've done something that others haven't been able to do. What's changed? And what I believe the magic ingredient is science. The science has finally come through. That by understanding all of the complicated networks of metabolism and how they intersect through mitochondrial functions, and how those mitochondrial functions can then go on to impact cell function and impact human health, we have an outline to put it together. And it really calls for, again, what people like you and so many others, the whole functional medicine community, have been screaming from the rooftops for decades and have been largely ignored, is I think that the science has finally come through to prove that, they were right after all. We need a systems approach.
Yeah.
And we need to look for root causes, and we can actually do this.
Well, Dr. Chris Palmer, thank you so much for bringing all that science together into such a cohesive way in your book, Brain Energy, which is a phenomenally good read, available in all leading bookstores. Just look it up, Brain Energy, Chris Palmer. And we are with you 100%. In the process of this revolution. We can call it metabolic psychiatry if we wish to give it a label, but we are talking about a systems-based approach which is absolutely supported fundamentally by the science that you represent so well. Thank you very much for coming on my podcast.
Thank you so much for having me on.